Professor Lee currently serves as an assistant professor at the Department of Radiology, Kyungpook National University Hospital in Daegu, Republic of Korea. He completed his RR training in Samsung Medical Center, and he has a big interest in treating vascular anomalies, especially arteriovenous malformation, and also pulmonary AVM, the placement of infrared IVC filter, and the embolotherapy. To date, he has published more than 30 papers and given 6 scientific presentations. So let us welcome Professor Lee. Professor Lee, you may begin with your presentation and start screen share. I will stop my screen share.
Thank you, Krishna. Can you hear me okay?
Yes, your voice is heard okay.
Yeah. Today, I'd like to talk about ultrasound guided angiographic classification. Oh. Can you see the slide?
Yes.
Okay. My topic is ultrasound guided treatment of AVM according to the angiographic classification. I have nothing to disclose, and today I'd like to talk about what is AVM, diagnostic modalities, angiographic classification of AVM, and how to treat the AVM according to the classification. And finally, I will share our experience of preoperative embolization of the AVM. Arteriovenous malformation, AVM, defines as an abnormal connection between the artery and vein, bypassing the normal intervening capillaries. It can cause pain, bleeding, ulceration, and even cardiac failure. For the patient, cosmetic and functional problems are the main issues. This slide shows a major pathophysiology of the AVM. If the arteriovenous shunt is created in the region, then normal intervening capillary can suffer the tissue ischemia because most of the blood flow goes to the low resistant shunt. Then normal neighboring capillary can suffer tissue ischemia. This patient showed fingertip necrosis, and she had palm AVM. It was her initial presentation. And cardiac overload is a very simple concept, and through the enlarged AV shunt, and most of the blood goes to the venous side, and entire body blood volume will be increased, and it can make a cardiac overload and even cardiac failure. And also, it is another important concept, venous hypertension. It can be caused by the arterialized venous pressure directly affect the vein side. So normal draining venous system is affected for the high pressured venous pressure. So uncontrolled venous hypertension related also can be occurred in the patient. So this patient had multiple foot and leg AVM. After the treatment, the lesion was spontaneously healed. Multidisciplinary clinic for vascular anomaly is very important to treat the patient. We founded this clinic from 2004. All of these departments joining the outpatient clinic, and we discussed the patient treatment plan and follow interval or modalities. And then, what is the goal of the AVM treatment? Complete cure is not so common, but it is limited according to the type of the AVM and the extent of the disease. Most of our procedures are performed for the palliative purpose to decrease distal ischemia and venous hypertension and prevent cardiac overload. And also for the patient, cosmetic problems are the big issues. So plastic surgery or laser therapy for the head and neck or facial AVM is needed. In the diagnostic modalities in AVM, Doppler ultrasound is very useful. It can give us flow data. This figure shows a typical AV shunt. This is a pre-procedural image, and this is after embolization of the lesion. The adjacent normal arterial flow returned to the normal pattern. So DUS can differentiate the feeding artery and draining vein. It is very important during the procedure. And this is the put AVM. What is the feeding artery and draining vein? This right one is a feeding artery. It has a high peak velocity shunt flow. And this left one is a reversed flow and much more lower peak velocity and shunt flow. So this is the vein and this is the feeding artery. And also guiding for the direct puncture is very important during the procedure. Doppler ultrasound can give us a safe puncture of the target nidus after identifying with the colored US. Then we can insert the needle through the for the target nidus. CT and MRI are also very useful technique. It can give us the extent of the disease, and time resolved MRI can give flow information of the disease. Then how to manage the AVM by the IR? These two papers are published from the Samsung Medical Center in South Korea. They treated more than 300 persons. So Professor Do always recommend the embolotherapy according to the angiographic type is very important. So I will share of the angiographic classification and treatment techniques according to the angiographic type. This table shows a Jodo classification of the AVM. Type 1 has less than 3 or less feeding artery and draining vein. Type 2 is multiple feeding arteries joining into the large draining vein. Type 3A is has a non-hypertrophied feeding artery and draining vein. It is very difficult to treat the lesion. Type 3B has a hypertrophied feeding artery and draining vein. Let's look at the embolization technique and materials. Flow control technique is very useful to avoid the devastating complications such as skin necrosis or nerve damage. Balloon occlusion catheter or direct compression during the sclerosing agent injection is sometimes helpful, and PP cup apply is another method for the flow control technique, and various embalming materials can be used. Let me show you an example of the flow control technique. This patient has a palm AVM. Control angiography shows AVM nidus and early draining veins. After to identify the connecting vessel with the nidus, I inject the powerful injection with my hand. Then angiography shows the finger artery originated from the nidus. So it is very difficult to embolize this lesion. However, PP cup implantation with the very slow injection, we can identify the nidus only. So you can see non-visualized draining vein or finger artery. So I like ethanol as an embolic material. Yeah, so it has a very low cost and effective and curative potential. It destructs the endothelial cell and make inflammatory, intensive inflammation. However, it is very painful drug, so we require general anesthesia. However, it is a very dangerous drug. To avoid pulmonary hypertension, the volume of the ethanol injection should be limited up to 3 milliliter per single bolus injection with the interval of 10 minutes. It is very important to avoid significant complication. So if total dose of the ethanol can be given up to 1 milliliter per kilogram. However, there is no Swan-Ganz catheter monitoring. The total dose should be reduced about 0.5 milliliter per kg. Coil and MBCA glue is also very useful to occlude the large venous sac or decrease the shunt flow prior to the ethanol injection. And onyx, it is very expensive drug, but it is not available for AVM in South Korea in extracranial AVM. There are 4 target vascular access method. One is the ultrasound guided, another is the fluoroscopic guided, and transarterial and transvenous access are commonly performed during the procedure. This is an example of ultrasound guided direct puncture. After identifying the target lesion, and small needle is inserted in the nidus, then blood is spontaneously go out from the needle. This shows this means the correct puncture of the nidus. Then check up angiography, and we can use ethanol or other embolic material very safely. This is another example of the fluoroscopic guided direct puncture. This patient has an extensive AVM, so you can see the numerous small feeding artery around here, and then most of the artery joining to the venous sac. So fluoroscopic guided needle was inserted and the lesion was ablazed by the ethanol. And also transarterial access is sometimes very useful. In this put AVM, it is very difficult to direct puncture of the needle lesions. So I insert the microcatheter this is the catheter tip, and I check the angiography, and after ethanol injection, follow-up angiography shows the markedly reduced vascular staining. Finally, this is the transvenous access. This patient has a complex back and paraspinal AVM. I want to embolize this venous sac first. So transvenous access from the femoral vein and agios vein, I could access this point, and I insert the many coils to occlude this venous sac. I will share our experience of how to treat the AVM according to the angiographic classification. It is very simple concept. This is the type 1 AVM. It has less than 3 feeding artery, so transarterial embolization is enough for some case. However, direct puncture or transvenous access can be also applied in this type of AVM. This patient had a renal AVM. You can see the single feeding artery and single draining vein. However, selective angiography shows parenchymal branch arising from the end of the feeding artery. At that time, I want to save those feeding artery parenchymal branch. Transvenous embolization was performed in this patient. This is the transvenous catheter, and coil embolization was performed, and final angiography shows we could save the parenchymal branch and without evidence of residual AVM. These are follow-up images. You can see the no parenchymal infarction or residual shunt flow. This is another case. The patient had a ear AVM. You can see the signal void on MRI. And this is the angiography, and you can see the feeding artery and draining vein and multiple draining vein. This is venous sac. So at that time, I used the onyx for the embolization to occlude the venous sac. This is the final image, and you can see the completely disappeared AV shunt, and ultrasound image shows there is no residual AVM in her ear. This is another type 1 AVM. The patient has a AV fistula because he has a history of trauma. So in this kind of AV fistula, we can also do the same strategy. I used multiple coils through the transarterial approach. The AVM was disappeared after the embolization, just one feeding artery embolization. Let's look at the type 2 AVM. It has multiple small arterioles and single draining vein. You can see the large venous sac and numerous feeding artery around the venous sac. On CT image, you can see the very early and large shunt flow goes to the IVC. In this situation, cardiac overload can make some problem for the patient. So in this type, direct puncture or transvenous access both are possible, but through the angiography, you can see some connection between the intra-iliac vein to the large venous sac. So I tried to insert the transvenous catheter and insert the many coils in this patient with a single session. After 74 coils were inserted in the pelvic cavity, and then 3 months follow-up CT shows there is no residual AV shunt and spontaneously regressed numerous feeding artery around the nidus. This is another type 2 AVM. The patient has a renal AVM. You can see the numerous tortuous feeding arteries around the venous sac. This is a venous sac. On ultrasound image, venous sac is directly connected with the large draining vein. So at that time, also I want to try the transvenous access, and this is the arterial, this is venous catheter, and I push it 5 detachable coils in this patient, and follow-up angiography shows spontaneously regressed numerous feeding artery, and there is no parenchymal infarction on follow-up CT scan. We reported this technique in type 2 renal AVM to the JBIR. We found it 100% devascularization after the embolization without evidence of the renal parenchymal infarction. It is a very transvenous approach, is very good strategy for the type 2 renal AVM. However, transarterial embolization always make some parenchymal infarction. This is an example. You can see the AVM in the kidney low pole. Selective angiography shows a tortuous feeding artery and vein. At that time, transvenous access was attempted but failed. So I used transarterial glue injection. However, you can see some parenchymal staining was gone. So follow-up CT shows there is a parenchymal infarction after the treatment in this patient. If the transvenous access is not possible, direct puncture of the nidus and coiling is effective for the patient. This patient has a scarf AVM. You can see the large venous sac and draining vein and numerous feeding artery. And I inserted a 5 French dilator in the sac, and I pushed the coils, and you can see the completely resolved the AVM in this patient. This is another example of the type 2 AVM. The patient lesion is loculated, and so preoperative embolization was requested, and I performed embolization. This is an initial angiography. Loculated AVM is here, and at first time I used transarterial glue injection, but most of the glue particles goes to the vein side and even to the lung. So I stopped the injection and I changed my plan to do another option. So this is the rate page of the arteriography. You can see the single draining vein here. So I want to embolize the draining vein with the 5 French dilator insertion. After draining vein embolization, this lesion venous sac was completely embolized. This is an adjacent radial artery. And follow completion angiography shows there is no residual early AV shunt. Then the patient goes to the OR to resect this lesion. This is a type 3A AVM. It has a non-hypertrophied feeding artery and draining vein. It is very difficult to direct puncture. So it is a very difficult type of the AVM to treat. In our hospital, we usually use bleomycin intra-arterial injection or ethanol, 50% ethanol injection with or without proximal balloon technique. This is an example of the bleomycin injection therapy. The patient has a porrid AVM. After selective catheterization with the microcatheter, I infused 20 milligram of bleomycin. After 6 months, the follow-up colored ultrasound shows there is no residual AVM. However, bleomycin effect is not so big. So in our experience, about 20% of the bleomycin therapy are the responder, and remaining 80% we should change the plan to more invasive or more toxic sclerosing agent to treat the lesion. This is on type 3A AVM. After transarterial glue injection, the patient received a flap operation, and then 2 years later, the lesion was recurred and additional glue injection was performed. However, the lesion was recurred recently, and I treated the lesion with the direct puncture. Even it has a very small calibered vessels. However, we try to the direct puncture and ethanol sclerotherapy. This image shows the final angiography markedly reduced the vascular staining without any complication. So nowadays, even in type 3A AVM, we want to use the direct puncture technique rather than the transarterial ethanol or ethanol injection. This is the type 3B AVM. It has a hypertrophied feeding artery and draining vein. Direct puncture and transarterial therapy both are possible. So in this patient, we treated transarterial ethanol and glue injection and direct puncture sclerotherapy with ethanol coils and glue. These are the initial angiography. Massive AVM on his posterior side. However, 5 sessions with a total 108 milliliter of the ethanol and glue and coil, the lesion was markedly improved. There is no early AV shunt. However, after final treatment, the patient's skin was had a problem. So unfortunately, the patient has to receive another surgery for the skin repair. This is a follow-up imaging. There is no residual AVM nowadays. This is an interesting case, and the patient had a hand AVM with uncontrolled finger ulcer and distal finger coldness. You can see the nidus here. With the under arteriographic guidance, I inserted many needles to the target for the nidus abrasion. After 2 sessions of ethanol sclerotherapy, the lesion was markedly reduced. You can see the reduced vascular staining, and the Stitch syndrome for the finger was markedly improved. The perfusion was markedly improved. And also, follow-up CT shows the reduced vascular structures, and her uncontrolled ulcer was spontaneously healed after 2 sessions of the treatment. This is another example of the AVM, type 3A and B. Previously, she received surgery and sclerotherapy, but residual AVM was still noted, and I inject the direct puncture of this lesion, this one, with ethanol, diluted ethanol, and follow angiography shows the markedly reduced vascular staining. She visited our clinic recently. The DUS shows there is no evidence residual AVM. This is another example, hand AVM. However, direct puncture angiography shows the finger artery arising from the nidus. So it is very difficult to treat. So I used the rubber band for the embolization, band compression technique. After band compression, angiography shows there is non-visualized finger artery, so we could ablate this nidus with ethanol. So this is the follow-up angiography and markedly reduced lesions without parenchymal perfusion defect. Let me show you a case of the complex AVM. Complex AVM requires multidisciplinary team approach, such as surgical resection, laser therapy, and also multi-sessions of the sclerotherapy is required. This patient is diagnosed as Parker-Weber syndrome. In 2005, his age was 5-year-old. There was some AVM nidus on his right leg. After 5 years, the lesion was rapidly aggravated, and you can see the enlarged IVC and internal iliac vein. However, at that time, his cardiac problem was noted, so we tried to amputate his leg to save his life. After 4 years later, however, the pelvic AVM was recurred, and then 3 sessions of the transarterial glue and coil embolization was performed. However, in 2016, CT shows the enlarged draining vein and numerous feeding arteries, and also you can see the scrotal AVM. At that time, this type was type 2 AVM, so you can see the numerous feeding arteries, multiple lumbar, internal iliac, and contralateral internal and scrotal branch, and also inferior epigastric artery was on feeders. So I want to embolize the large venous sac first. With the direct puncture like this, I insert the 5 French sheaths and 5 French catheter in here, and then 60 pushable and detachable coils were deployed in the region. And follow-up angiography shows markedly improved large venous sac is not visualized. However, small residual AVM is noted in the scrotal area. In this year, CT shows the markedly improved pelvic AVM. However, you can see the residual scrotal AVM and scrotal swelling. So we tried the sclerotherapy again. You can see the residual AVM here. So I used the ethanol sclerotherapy for the scrotal AVM. After that, all the residual AVM was disappeared in this patient. After the treatment, decreased the venous hypertension and scrotal swelling. You can see the markedly decreased scrotal swelling compared to the previous imaging. The patient became a college student. This is the recent angiography and markedly improved and still very stable condition nowadays. He is very happy nowadays. So our team are both also very happy for this patient. Let's look at the embolization and surgical resection for AVM management in our hospital. Usually preoperative embolization is performed by IR and same day surgical excision and closure or prep surgery performed by the plastic surgeon. This patient has axilla AVM. You can see the capillary malformation component in the dermis. So atherosclerotherapy alone, it can make a large skin necrosis. So we planned the preoperative embolization and surgery. This is an initial angiography. At first, I used direct puncture of the dominant vein and coil embolization was performed because to avoid the embolism material migration to the systemic vein. After that, after coil embolization of the dominant vein, I used the directed puncture and glue injection was performed like this, and check the angiography again and puncture another side. And this is a glue embolization. Some glue was migrated to systemic vein, but that's okay. And this is a direct puncture and glue injection. And fluoroscopic guided puncture, and also can be performed if the lesion is deeply located, and glue injection to occlude the entire vascular structures. After that, this is another direct puncture. And then finally, transarterial glue injection was performed to occlude the residual vascular lesions. And this lesion was also embolized with the glue. This is a glue injection. Final angiography shows markedly reduced the vascular staining. And then the patient moved to the operation room, and the lesion was resected by the plastic surgeon, and primary close was performed. We evaluated the outcome of our strategy, and finally 20 patients was enrolled for the analysis. This table shows the proper angiographic technique, embolization technique. And we measured the angiographic devascularization rate. This patient had a lip AVM. We embolized the transarterial glue embolization for 3 branch, and final angiography shows the complete devascularization. We measured it as a 100% devascularization. And in this patient has a nose AVM. I used the coil and glue for the embolization. However, small residual lesion is noted. So we measured 80% devascularization in this patient. In our data, overall devascularization rate was 83% after preoperative embolization. However, type 3A and type 3A plus B shows the lower rate than the other types. And also, only one, except one type 2 renal AVM patient, 19 patients received the proper angiographic technique. This is an example of an inappropriated embolized patient. This patient has a nose AVM. You can see the large venous sac and numerous feeding artery from ECA and ICA territory. However, at that time, transarterial glue injection was performed, but you can see the majority of the venous sac is still visualized on follow-up angiography. After surgery, however, the marginal recurrence was noted in this patient. In our data, 65% shows complete devascularization after follow-up. However, 7 patients showed residual lesion, 2 was near complete, 4 were partially improved, and residual AVM was noted in 1 patient. This patient received had a chin AVM. After glue embolization, the lesion was completely disappeared. After the surgical resection, there was no recurrence. However, I showed this slide previously, but the patient showed 100% devascularization after the embolization. However, on follow-up DUS, you can see the still residual shunt flow around the surgical resection margin. However, the patient do not had any symptom or sign for this small shunt flow. This patient received transarterial glue injection and residual lesion, about 20% vascular lesions were remained. However, this patient lesion was progressed and she had to receive more than 3 sessions of sclerotherapy. On the follow-up, there was no symptom or image recurrence in completely devascularized patient in preoperative embolization. However, 7 had a residual AVM. And type 3A and type 3A plus B shows more residual lesion than other types. It is very important because this type 3A and type 3A plus B AVM is very difficult to treat. So in our data, angiographic embolus surgery had a 65 devascularization rate, and type 3A and type 3B shows a poor outcome. This is my final last slide, and multidisciplinary team approach is important to treat the AVM, and select the treatment strategy according to the angiographic classification is essential for AVM treatment to reduce the significant serious complication and to improve the treatment outcome. And also, embolization plus surgery can be a good option for AVM management. Thank you for your attention, and this is our team.